the end of the day. Well, welcome. My name is Gary Carneal, and I'm the Senior Policy Advisor for the Kennedy Forum. And it's been my privilege to support Patrick and his mission for almost the past 4 years. And so today's program is called Advancing Justice, Pathways to Making Mental Health and Addiction Parity a Reality. So I'm excited because I think we're going to have a lot of different stakeholders and perspectives. You know, one of the things that I think sometimes we forget is really the parity compliance moving towards mental health equity. It's really a multidimensional challenge with lots of moving parts. And I think one of the things I took away from yesterday is just so important for us not only to become technical experts in our different areas of what we're trying to do, but to create those empathetic bonds and form a community. So what I love about today is we have people from the regulatory community, people who are consumer and provider advocates. We have some industry members. And so I think it's going to be very interesting. We have consumers, patients. So it's going to be exciting to kind of get people's different perspectives. So welcome to the session today. I did want to note that the session today is going to be recorded, and a link to that recording will be made available to everybody who attends today. So it's my pleasure to introduce Patrick Kennedy, who really needs no introduction, but I did want to say one thing that many people don't know is with Patrick's incredible skills of speaking, one of the things you may not realize is he's actually behind the scenes really very much of a technician, an engineer, and has been working with us and in supporting a lot of the work that the Kennedy Forum team has put out in terms of really the specifics of how do you comply with the parity law. So Patrick.
Well, thank you. Thank you very much, Gary, and I appreciate your experience, your knowledge, and your ability to pull a lot of these moving parts together and really help us develop an engine room, the boiler room, basically in the back, to try to propel a very, as you said, complex set of factors that all need to be aligned if we're to try to move this whole message forward. And the message itself, since we've just come off celebrating the 50th anniversary of MLK and the cause of civil rights, human rights, it's appropriate to know that on the 50th anniversary of Dr. King's assassination and all that he stood for, we're marking the 10th anniversary of the Mental Health Parity and Addiction Equity Act. And, you know, obviously I think the two are very connected in the sense that the fight for social justice that Dr. King really brought into the consciousness of our country is a fight that has widened the circle of opportunity for millions of Americans on so many fronts. And the fight for people who have suffered from a mental illness and intellectual and developmental disability and substance use disorders, that fight for inclusion and justice is part of the broader fight for equal rights. And I see the parity fight as a fight to end the separate and unequal treatment of people who have a brain illness. And I see it not only obviously as a fight to bring equity in the payment for health care and coverage for that health care in insurance for people with mental illnesses and addictions, but I also see it as part of a fight for recognizing the human dignity of people who are marginalized and discriminated against and dismissed in our society because their illness has been so misunderstood and therefore led to their alienation in our society. So I want you all to know that what you're doing today is not simply advancing the very sound legal argument that it's long past time that we include the brain in health insurance coverage and reimburse equally along all 6 categories of care: inpatient in-network, outpatient in-network, inpatient out-of-network, outpatient out-of-network, pharmacy benefits, and emergency room benefits, that those are equal as medical and surgical benefits, but that beneath that fight for equality is saving the human dignity of people who are already suffering the indignity of an illness that makes them feel so ashamed of themselves. So I hope, as we remember the extraordinary times of Dr. King and my uncle Robert Kennedy, and we think about that NAACP picking jurisdictions where they could create new common law standards that would affect the entire nation in terms of the application and implementation of the 1964 Civil Rights Act, that you think of yourselves as a modern-day version of an NAACP, picking and choosing those jurisdictions, those cases, those opportunities to establish a new common law standard, if you will, amongst payers on what it means to treat people with these illnesses equally as we would those with any other set of illnesses. And this is a profound time for you all to be here, not only because of the historical context that I'm speaking of, but because of the present-day challenge of the fact that these illnesses are a public health crisis of an order and dimension our country has rarely seen in its history. But what is so breathtaking is the fact that we are silent as a nation, in spite of all the headlines, in spite of all the newscasts, in spite of draconian statistics of the number of our fellow Americans who are dying of overdose and suicide. We're still doing nothing. Nothing. $500 million a year towards a public health crisis that's claiming 3 times what the AIDS crisis claimed in the height of its incidence. And they were spending $24 billion a year, and we're spending less than $500 million a year. What is going on here? And so when you're fighting this fight for parity, understand we're not only blocking and tackling to implement a law that was passed by the United States Congress, signed by a President of the United States, and finally bringing justice to Americans that have been long denied equal coverage. But you're fighting stigma. You're fighting those perverse attitudes that say that your members of your family who are suffering from these illnesses are somehow not worthy of the same love and attention and dignity as anyone suffering from any other illness. So I hope you know that as you're going through today and you hear all these tremendous presentations, that you think of what you're doing in that context. I'll just say I'm so grateful for my good friend Matt Bowman, who I worked with Garen Staglin, and he said, what is this parity? What is this parity? And next thing I knew, he was having his foundation fund a very large study, the Millman, to really reveal the data points on how parity was not being implemented. Now, the notion that Millman would come out with a report, given the fact they do so much on behalf of the payers, that says so categorically that there is not parity in coverage across the country is should really fuel our efforts today, just as a set of context. Inpatient mental health and substance use disorder treatment occurs out of net 4 times more often than inpatient medical care. Outpatient mental health, more than 5 times as likely to be out of network. Of course, you have some examples in New Hampshire and Utah, nearly treatment in outpatient facility 20 times more likely. It means the cost of co-pays and deductibles and all the rest so much higher for those. And of course, the disparity between commercial insurance reimbursement and Medicare reimbursement rates is all documented in this Millman report. So I thank Matt Bowman and I thank Henry Harbin. Henry has been, in the trenches, to say the least, for this movement, as all of us know. He's ubiquitous. Every room I walk into, there's Henry Harbin. I go in, there's Henry Harbin. And then I try to check up on my emails, and then I got 10 more emails from Henry Harbin about what I need to do next. And thank God that we have someone like Henry helping us out. So Henry, could you come up and tell us what we need to do from here?
Thank you, Patrick. So I don't know how I got picked to do the retrospective. Maybe I may be the oldest guy here or something, or because I've been fiddling with this thing for 30 plus years, either at state or federal level, trying to get the statute passed and then the regulations. So I'm going to comment on several things. One is just the timeline, so we're all on the same page about the dates of the law, and then give some idea about how I feel the implementation of it's going in different categories. So the law passed in 2008, as Patrick mentioned, and it has that weird history of being part of the TARP bill, or was the TARP bill. The interim final rules came out in 2010, so that was pretty quick, I think, in terms of getting out, and those rules were very good, I think. They laid out a lot of clarity about the classifications and the quantitative and non-quantitative limitations. The final rule, and it was binding, so the people were regulated by it from that day or the next year as it rolled in. The final rule came out in 2013, and then the Medicaid rules came out in 2016. That was really, frankly, a terrible delay. I mean, as we all know, Medicaid is the largest payer for mental health and substance abuse, partly because benefits are constrained on the commercial. On the medical side, it's commercial insurance is the biggest insurer. But that was unfortunate that didn't come out till almost 10 years after the law passed. So, but during that time, both Department of Labor and HHS were issuing a lot of sub-regulatory guidance, FAQs, additional clarification. They've been doing that almost continuously as they have heard some of the problems, some of the access issues, the complaints from providers and consumers, and they've provided a lot of clarity in doing that. So, okay, so that's the timelines of the regulatory process. So how is it going? Well, I think I would say you have to split the compliance up into a couple of categories. So in the area of treatment limitations, the quantitative treatment limitations, like a 30-day, say, cap on inpatient days opposed to as compared to medical, and on the financial requirements, co-pays, deductibles, I would say compliance has been reasonably good there. There are clearer guidelines on that. I think there's been reasonably good compliance from the insurance companies. And so I'd give that a grade of a B. I'm going to try to grade each area because I don't know how else to do it. I did ask Amy how she would like me to grade the Department of Labor, but she wisely deferred and said, I'm not doing that. So, but I might give it a higher grade, but there's such a lack of transparency a lot of times on whether these rules and processes, even on the financial requirements. So one of the things that bothers me, and it may be parity compliant, but a lot of employers and health plans have put the mental health and substance abuse professionals in the same category as they do medical specialists. And so for many plans, particularly high deductible now, that means you pay a higher copay, you have to apply the deductibles, the coinsurance, which you don't do that for primary care. So, and I think some of that, the parity processes allow that to be compliant, but I don't know who's actually checking that. Is it done correctly? Because that's a major barrier, whether it's compliant or not compliant. Okay, now let's get to the problem area. So the non-quantitative treatment limitations. The problem with going to a parity meeting is you do, as Gary said, you sort of become moving into the nerd world of parity language, and this is one of them. But when the regulations came out, they split the treatment limitations part of the law into two parts, a quantitative limit and a non-quantitative. So the non-quantitative basically applies to any medical management protocol, whether it's pre-cert, experimental, non-experimental, reimbursement, has to be done in a comparable and no more stringent manner than what happens on the medical. So this is the area where we've had the most problem, where most of the lawsuits are around, the appeals are around. When you read these secret shopper surveys, you read consumer surveys that just came out last month from NAMI about access problems. These are all issues around problems with access and having to do with the NQTLs. So I would say there's been a little progress in that some of the plans have backed off some of the micromanagement of, like, say, med visits by psychiatrists. You know, they've stopped doing that except maybe once a year. Some of them have backed off some of the concurrent review on outpatient, but major problems are still there. And what are they? Well, I would say one of the biggest, in addition to the Millman documentation about outcomes, is the fact that, to my knowledge, no plan has yet complied with the disclosure of how they do and apply an NQTL of any kind when there's an appeal or a lawsuit, but particularly on the appeal basis. So I've seen hundreds of these, so maybe there is an example of a health plan that actually, in response, where they ask you, how do you compare this behavioral health constraint to the medical constraint, they followed the guidelines as laid out by Amy Turner and the Department of Labor, which laid it out fairly clearly what they had to do. I've never seen one that was compliant. So I'll just make the charge. If there's some plans here, if you have one, show it to us, because I've never seen it. And I've seen hundreds of these appeals. So put yourself in the situation of a consumer. You think there's a parity violation. You got denied. You make an appeal, and you say, okay, I think there's a parity violation here. I don't know, because I have to see what you did on the medical side. You can manage the behavioral benefit any way you want to, as long as it's done comparable to the medical. So what you get back is, well, in a significant number of cases, you get nothing back, no response at all. The next thing is they may give you a link to the medical criteria. Most of the behavioral criteria, frankly, are public. But the medical criteria, they may say, well, go look at this 900-page document, and yes, we're in compliance. No more detail. They don't tell you what factors, they don't tell you the standards, they don't tell you the analysis, and the conclusion that you, as a consumer, forget a lawyer, just could say, oh, okay, I see what they did on inpatient medical. They laid it out, summarized it, and now I know this is whether they're compliant. So the only way you're going to find that out is a lawsuit, assuming you can go that far. So that's one major problem. And while the Department of Labor has given consistently fairly clear guidance for several years on the steps that have to be answered here, in a response like that, there's been no compliance. So let's see. So what's the other category that goes into my thinking, like, well, how would you grade this in terms of implementation? And the Millman Report that Patrick referenced is a good example. It's the most detailed documentation we've got of actual outcomes to access. And while we realize that we didn't name any insurers in that, Millman didn't, and you can't say for sure that this level of outcome disparity is a parity violation. It looks like they might be. So I'm going to read a couple of summaries that are different than what's up here on the conclusions of this. 31% of outpatient facility behavioral health care was accessed out of network for mental health, and only 5.5% for medical. That's a big difference. And that doubled over the 3 years. So the Millman study, I should back up. So the Millman study looked at 42 million patients' claims records in all 50 states over 3 years, 2013 to 2015. All of those years were regulated by the parity regulations. So these are not non-parity regulated years. So in those 3 years, the amount of out-of-network purchasing for services for behavioral doubled. So no impact from the parity law. In fact, it got worse. On the inpatient side, 16.7% of inpatient facility healthcare was accessed out of network. And we all know inpatient's very expensive, whether it's medical or behavioral. So thinking about that, you're getting less, maybe 50, 60% of the reimbursement for that, and you're paying out of pocket for the rest. 4% for medical, very low. On the outpatient office visits, 18.7% of behavioral health office visits were out of network, and 3.7% for primary care and medical specialists. So one conclusion of that is the plans have done a great job of keeping medical out-of-network purchasing very low. And there are a lot of medical specialists that are harder to recruit than psychiatrists. So let's congratulate them. Now we'd like to see them do the same thing on the mental health side. So one other summary piece of data on this. As of 2015, the out-of-network use of behavioral health inpatient care as compared to medical was 800% higher in California, New York, and Rhode Island, and over 1,000% higher in Connecticut, Florida, New Jersey, Pennsylvania, New Hampshire. They represent 30% of the population, that group. That is astounding statistic of a disparity. And I'd like to add that, when this data came out, many plans said, well, this is a market problem. There are not enough psychiatrists. We can't get them. They won't come in. The inpatient and outpatient facility data, which have tremendous, even worse disparities than the office, that's not primarily determined by how many psychiatrists are. Those inpatient units already have people. A lot of the outpatient facilities have a minimal use of psychiatrists. So you really can't explain the other two categories, the non-office space, as having much to do with the psychiatrist shortage. So there are clearly other factors going on here. On the reimbursement side, one final statistic on that. 2015, there were 24 states with reimbursement disparities ranging from 30 to 70%. So that means that mental health professionals, substance abuse professionals were paid that much less than what medical specialists and primary care docs for similar services. So that's bad. I mean, there's no way you can put any kind of positive spin on that. But then there was another study that just came out the day after the Millman, done by Truven and funded by SAMHSA. So it was a government-funded study. They looked at 30 million patients' records in a claims database, and they picked out 3.8 million of that. And the way they were, in a sense, more targeted in their summary or their analysis than Millman, because they looked at the same E&M codes, the evaluation management codes that are billed most commonly by physicians and nurse practitioners, et cetera, for office-based care. So they took the same codes for the medical side and the behavioral side, and they picked the claim, the diagnosis they were billing for were mental health and substance abuse diagnoses. So they didn't not only looked at the same code where there's disparity, but they were treating a mental health condition. And even there, it was 20% lower. So basically you're saying like, well, if my internist saw me for depression, they get 20% more than my psychiatrist seeing me. Well, now that gets even closer to whether you'd have to say that looks like pretty clearly a parity violation. I don't know how you could do an analysis and say, well, they had the same diagnosis, same code, okay, and still didn't pay the same. So, okay, what grade, I'll ask you all what grade you would give, but from my viewpoint, this is a D in terms of the compliance by the plans with reasonably good guidance from the Department of Labor, and yet we're here 10 years later and there's this level of disparity. I would say, let's forget we had a parity law. This is a terrible outcome if you had no parity law, right? What insurer would go to sell their insurance and say, hey, you have cancer, anybody with cancer, we're offering this in the state now, 30% of the time, if you need any kind of non-office-based care, it's out of network. Do you think they would ever sell any insurance that state? I don't think so. That's what you're doing with mental health and substance abuse. So I would give DOL, however, I'd give them a B-, since I couldn't get Amy to do it, on their guidance, because I don't think they've given enough examples. I think they've given a lot of clear guidance that is not followed, but they could give further. And I think the bigger problem, though, is the enforcement. So these plans, I just gave you the example, 100% noncompliance to my knowledge on the disclosure, and I don't know of any that have been sanctioned either. They may have been, but we don't know it, right, by the Department of Labor or any state regulator. So that's my comments. Gary, you want to say anything? Have I run out of time? Or?
We have a few minutes to take some questions.
Okay. The Millman study did both, okay? The psychiatrists and nurse practitioners, advanced nurse practitioners, can all bill an evaluation and management code, that particular CPT code. So there they were comparing those two sets of providers the same as the medical and primary care. For the psychologists and social workers, according to Medicare rules, they can't bill an E&M code, so they have other office-based psychotherapy codes. So there they compared them to, actually the same way is, they looked at Medicare allowables. So Medicare essentially has a national fee schedule by geographic. They say, well, we normally pay psychologists, let's say, $90 for a 45-minute visit. So what they looked at was, if the Medicare allowable said internal medicine people for a brief office visit get 100 and the psychologists get 90, what did the commercial plans do vis-a-vis that schedule? And what they found is they generally upped the medical folks and reduced or kept the same the psychologist, social worker, et cetera. So that's the nature of the disparity. Other? Yeah.
A question regarding the findings, the disparity between, thanks so much. On the Millman Report, could you explain a little bit about why there's such a significant difference in driving a higher out-of-network usage for mental health compared to medical? Was it the way the health plans have set up and designed the network itself?
Yeah, absolutely. I mean, so the reimbursement obviously contributes to that, right? If you're getting paid less than your colleagues to be an in-network provider, and once you become in-network, you have to take their rates. You don't have a choice to. So that's one, but there are other things that all that goes into building a network. So it's the number of practitioners you have. It's what kind of micromanagement rules you have. In my talking to health plans around the country over the last 20 years I've been in this business, when they've got they have shortages in the other areas, right? I mean, how hard is it to get a dermatology? Ever try to get a dermatology appointment anytime soon? Or certain oncologists? So they regularly monitor this by geographic. Are they short? Do they need to do something? So there's all these medical management protocols can be used to facilitate access or to make it harder. Other?
We're finding some companies that are disqualifying the consumer from benefits because they didn't get pre-auth. So they might have gone into on an emergency basis on a Saturday, and the treatment program is willing to take the chance. And because the company isn't open, and the Federal Blue might be one of those. So I'm curious if you found anything on that.
Well, again, like all of these protocols, pre-cert, you could do it if you do it on the medical side. If you don't do it on the medical side, it's basically a parity violation. So that's where I'm saying, so let's suppose you appealed that and said, well, look, I got denied because it wasn't, pre-authorized, right? You went emergency room. I want to know, do you do that same thing on medical conditions for heart disease and diabetes?
Right.
Based on the history we've seen so far, they won't answer that question. So you're left with a situation that you've asked me a question I can't answer. You can't answer it either. You'll never know whether there was even ever compliance or not.
Sure. If I go in with a heart attack, I would be pretty surprised if they didn't cover me.
Correct. But what you need to know is, well, how did they apply that on the medical side? What standards they use, how they compared it, how frequently they do that on the medical side. That's what would determine whether there's a parity violation. So here we are with 10 years later, and the poor consumer or provider, if they're acting on behalf of the consumer, they have no idea today in any of these situations whether there was even a parity violation that occurred.
Do you have any knowledge about the disposition of any of these lawsuits? So you're saying that, what happens? I mean, doesn't the judge force the companies to give the information that would, answer that question?
I'm gonna let Gary answer that. There's another whole meeting this afternoon where a lot of the lawyers talk, but there are a lot of lawsuits, and there would be like another hour to try to explain all the dispositions of those. But let's just say there's a lot of challenges that are going on.
So just strategically,
Right.
people can appeal and we can issue these lawsuits and try to go that long road. Or we could try to develop some type of consumer movement through these Parity Registry where we get a handful of people like some of those who have showed up today to tell their story. And say to these AGs, listen, there's where there's smoke, there may be fire, and here, thanks to the Parity Registry, we've got, a couple dozen cases that are pretty slam dunk, and, can you call over and see whether you can't get something done because you're the Attorney General of the state. So obviously we have the fellow Michael Reisman here in the room who's helping on this issue, who's
he's gonna
done
solve this, right?
But it would be good to kind of comment, Henry,
Yeah,
on
okay.
what that looks like in terms of an avenue for redress.
That's a great question. Frankly, a lot of this could be resolved without lawsuits, without appeals, if the state regulators and the federal regulators did a detailed NQTL audit, okay? Use your money wisely, go to the top groups, because if you get the top 3 or 4 insurers doing this complying, the others are going to follow suit. So you can't tell a lot of times from this disparate data, was there in fact a parity violation? But it certainly would trigger an audit. And the regulators don't have this problem of disclosure. They get everything, right? As to the Attorney General's office, or a lawsuit, they can, after a lot of fights, can get everything. But so I think it's the employers need to step up, Patrick, because they're acting, the employers are liable under the parity law as well as the insurers. So they're acting as and this data that we looked at, by the way, is available to every employer for their employees from their insurer. And so, the irony here is all Millman did was look at the plan's data. I mean, they could have looked at any of this anytime they wanted. So to me, the issue is to do these detailed NQTL audits. Okay. Thanks, Gary.
So what's exciting about the session today is we get to switch gears, and now I want you all to put your consumer hat on. This discussion about parity compliance and the things that state and federal regulators can be doing and what health plans should be doing will continue with some of the later presentations. But just imagine for a minute that you or your child has a significant mental health or addiction issue. And it gets back to one of the questions earlier about the utilization management. So part of this just gets tied to when there's a denial of care, there's a denial of care. And how do you activate your family to make sure that your loved one gets the care they need? So it's my pleasure to introduce Julie and Victor Hoodie, who the Kennedy Forum's had a chance to work with for about 9 months, but you're about to hear an amazing story, and with some good news, but some challenges ahead. And I just also want to quickly acknowledge Kelly Showalter, who's helped with helping with some of their appeals. So Julie and Victor, why don't you come on up and tell your story?
Hi, everyone. We're going to take you on a journey that we've had 365 days of schizophrenia. This week marks the 365th day that we've been dealing with our son with schizophrenia. I want to give you a little back view of him before my husband talks about the insurance. This is our son, Joe. He loved to tinker. He was in the maker movement. He likes to build things and encourage others to build. If you have an idea, make it and show it to people. He made this marshmallow cannon that you'll see pictures of later. But there'll be good pictures, I'm sorry. The bracelets that we have here, he has come up with a motto of don't be bored, make something. So we got a bunch of bracelets and gave them out all over the world for kids to remember. Don't be bored. You know, if you have a little idea, let's make something. So we got involved in the maker movement, which is an environment that tech enthusiasts, crafters, educators, engineers, and all come together to show what they've made and share with fellow makers. Joey got some tickets for his birthday, but he decided very early on that he was not going to just go and look at everything. He wanted to go and make and be part of this. And this is how this is called the Extreme Marshmallow Cannon. And he would be upset if I didn't tell you that it shoots 176 feet at 40 PSI. It's fun. So here's the picture that I was telling you about. So from the popularity of the Extreme Marshmallow Cannon came some pretty exciting things for him. He was invited to the White House Science Fair in 2012. This is the actual picture. We get a lot of questions of, is this Photoshopped? Did this really happen? Just, if you Google it, it's there.
And the video that goes with it, the full video taping of President Obama visiting his booth at the science fair is online.
It's pretty exciting.
Google Joey Hootie and you'll find it there.
So then he also got invited to sit with Michelle Obama at the State of the Union. So, of course, what teenager is not going to try to have a selfie with the First Lady? So these are the things that Joey invented and made new products. He decided early on that he wanted to make products for a beginner maker to share a fast, let's build it and it works instantly. So the one that's red is called his 3x3x3 LED shield, and it sticks on top of a microcontroller. So it's instant, fast, and it works, which he thought was great. Then we have the surface mount one, which does potentially the same thing. But the big one on the bottom right, he made by working. He was the youngest intern ever hired at Intel. So he was tasked to build something really cool, and lights are very cool. So he showed this at the White House, and at CES and a lot of other places around the world. So that leads me into all around the world. Joey's had a very exciting life. We traveled to China 3 times for him to speak, Rome twice, and Paris twice. He would just get up on the stage and I would say to him, Joe, are you ready? Are you prepared? And he goes, I'm going to wing it. And always did an amazing job. Sorry. Okay, the media also loved Joey's success. After he was at the White House Science Fair, we went on a tour. We got back and my phone had a million emails. I don't get the amount of emails that maybe Patrick gets, but a couple there, here and there. But everybody wanted to have Joey be part of an interview, hear about the marshmallow cannon. So that was quite fun. So these are some of the headlines that have been said about Joey in the past, before this 365-day journey. So here we are at the 365 days. This is the last picture that we have of him. Sorry. In January of 2017, our life, as we knew it before, has changed forever. While working in China, let me back up, I'm sorry. He was asked to have a job in China after a semester of school, and he was very excited, so we let him go. It was in the field that he wanted, engineering. He got to build things, help children, perfect. So while he was in China, he started showing some signs of mental illness. It wasn't until we were able to get him back to the United States that we learned the severity of it. Obviously, I'm his mom, and I just thought, oh, he just needs to come back to the United States. He just needs a hug from his mom. Everything will be fine. When he got off the airplane in Ohio, that's the facility area that we found, the escort gentleman that escorted him from China to the United States told me, Mrs. Hootie, I'm really sorry, but you have an extremely sick young man on your hands. That was pretty earth-shattering to me. Also, Joey came off of the plane with a suit and tie on, which I thought was a little odd, being the long flight, and he said that he was here to speak to the United Nations about China spying on him. So he didn't understand where or what was going on. Sorry. The challenges of navigating the financial aspects of treatment was when we decided to go public. We can't help others change laws and make a difference if we don't speak up about mental illness. It's okay to speak about brain disease, schizophrenia, bipolar, and depression. They're words, and they make a difference if you speak about them. Don't be ashamed of your story or anyone else's story that you've heard. It can make a difference to others. We cherish all the wonderful past that we have with Joey and continue to fight for him every day in the future. Now, I'd like to pass this stage over to my husband, and he will speak of the stressful challenges we and other families face with treatment and the insurance providers.
Well, thank you everyone for being here. Patrick, thank you for bringing us into this community. Gary, thank you for all your help. But people, we need to do something. This is a tragedy that we live with. It's our life now, every day. So this is kind of the journey of our 365 days that Joe has faced. Like my wife said, it started in January, and we noticed his delusions and paranoia. Still can't do this.
For some reason, I can get through this a little bit easier than he can. I don't know why, but I'm going to kind of just read to you his portion of the slides because we practiced our own. So this is a little, January 15th was when we noticed the paranoia and the delusional thinking while he was living in China. The 22nd is when we were able to get him to fly back. Excuse me, one second. Oh, so January 22nd, he was scheduled to get on an airplane and fly back to the United States. He had another idea. He would not get on the plane. He saw on the TV that there was, the Women's March was happening that day. And so from his viewpoint, he thought that there was too much unrest in the United States because he just saw clumps of people and it made him scared. So that day he hung up the phone with us at the airport and we didn't hear from him for about 5 days. What do you do when your child just drops off the face of the earth for 5 days? My cousin's husband works for the embassy. So we called him and said, hey, this is what's going on. What do? We need some guidance because we were kind of spiraling out of control. So they hooked us up with the embassy in Hong Kong. They were fantastic people. So on the 26th, Joey called us from Hong Kong. He was at a psychiatric hospital and apparently had gotten picked up at the Hong Kong airport. He was acting irrationally and told the police there that he thought he had a tumor in his brain and needed an MRI. So he was also taking pictures of at the airport, so he was making people nervous. So on January 3rd, he arrived to the airport in Ohio from the story that I told you. Between February 3rd and March 1st, he received stabilization in a facility in Ohio. We are originally from Ohio, so it was a perfect fit because we had family and friends around us to support us in the journey. So then March 1st to March 12th, he transitioned to the out-of-network portion of the hospital. One hallway was in-network, and you literally walked 3 steps, and it became an out-of-network facility. It doesn't make sense to us. That is the location where he got the diagnosis of schizophrenia. March 13th through June 9th, we transferred him from Ohio to another facility in Tennessee. We had the diagnosis. It was now trying to jump in and treat this and get the ball rolling. So after he stayed there enough of the time that the insurance said, okay, you're done. Basically, you need to go home. And we're thinking this kid can't go home. He still is seeing things. He was schizophrenic. Need I say more? So on June 10th, we transferred him to a group recovery home in California, and that is where he lives today. You're good?
Thank you. So you see this path that he's taken, and you're probably saying, well, why so many locations? Why are you moving him around? It's because of the cost and the doctors that can service him. You know, we tried to stay in Arizona, but everyone we talked to could not refer us to a good location. The locations that we found, they're the best. We wanted to make sure he got the best services that he could. But each of those locations were out of network and were expensive. So we had to manage our expenses here as best as we could, and we're running out of money. But if he stayed in that out-of-network facility in Ohio, it was $51,000 a month, folks. Yeah, I'm not making this up. $51,000 a month. So we went to a facility that was dual diagnosis for his age range in Tennessee for a bargain of $28,000 a month. And now he's at a group home, doing well, getting a job, volunteering, actually being a mentor to other people, other men living with him. The group home has 16 beds in it for a cost of $9,500 a month. Right now we're working to bring him home because we can't afford that. So here's what we've spent
In 365 days.
in 365 days. Out of pocket, $274,000. And what have these providers billed the insurance company? Over $400,000. Why is that? What's happening here, folks? These providers are upcharging all the services that they're providing to us for a profit. This is where they're looking to make additional profit on their patients that they're servicing. Note at the bottom, 11 days in a facility in Hong Kong, they billed us $1,000. So what are the challenges we've been facing here? Lack of quality facilities. You know, we were fortunate that we had someone that was familiar with mental health in California and referred us to another expert that knew the different facilities. That gave us a starting point. And we spent 2 days calling facilities, asking them, you know, do you have room, first of all? A lot of the places we called didn't have room. Secondly, what was your cost? That's where we learned. I mean, $58,000, $28,000, $32,000, and they were all private pay, out-of-network facilities. And very few. Of course, a lot of these places have a lack of doctors and treatment professionals. We saw the turnover even in a short period of time our son was at some of these facilities. And of course, the extreme cost of care. Now, challenges with the insurance plans and providers. So, you know, sure, we got him in to a facility. He's getting treatment, good treatment. He's progressing. But my wife's job is battling the insurance company now and the providers to get the billing proper and complete.
It's a full-time job.
It's a full-time job for her. So the lack of, and Henry kind of mentioned this, kind of alluded to this a little bit, objective criteria for authorizing and approving the type of care and the length of care. We were battling day to day for authorization. It wasn't, okay, we think one more week of treatment would be good. It was, is one more day of treatment still good for him? And we had to sit around each day waiting for that phone call. Do we have to move him tomorrow? Or is he good for another week at this facility? It was daily approval, authorization. The lack of in-network doctors and treatment professionals. Again, I mentioned that earlier. Good luck trying to find an in-network provider. Very difficult these days. And then the inconsistent processing of the claims. Amazing, folks. Amazing. Not only from the provider side of what they're billing and providing for documentation to get the approvals on those, but then on the claim side, paying them consistently for the same service, for the same number of days. And this is an example of what we faced here. If you look at showing you 3 different claims. These are 3 separate claims. The first one, it took 3 attempts to get it right, or to get to I won't say right, to get it to a final billing state. The second one took 4 days, and the last one took 6 days. Or 6 tries, I'm sorry, not days, but attempts. And you can see in the amount billed column, the amount that the provider is billing changes from submission to submission. How does it change from submission to submission for that same service? And if you look at your plan paid amount, it changed as well. And I could look at a same, like the first one is a 2-day in-stay treatment, which we paid $850 a day, and they were billing $1,850 a day. I could look at the next 2 days after these 2 days, and they could have billed an entirely different amount. And it happened. My spreadsheet, which Gary can attest to, is probably this long for a 30-day stay in one facility. These claims get reprocessed over and over. I couldn't tell you what my deductible is, what my out-of-pocket is, which goes against other medical bills that my family has. So what am my wife, unfortunately, has rheumatoid arthritis and has treatment. It's a shell game as to what should I be paying for this claim versus that claim. And to this day, I asked for a breakdown of how my deductibles and copay and out-of-pocket was charged, and they cannot provide it. I said, show me for my family how my deductibles and claim and out-of-pocket was paid. After 3 attempts, they still have not provided it. We have written to different agencies asking for help. Nothing. No help. Sorry, Department of Labor, we did right. No response. So other provider concerns. So when you go to a private provider, you have to pay in advance, or they won't let you in the doors, right? So come up with $58,000 out of pocket for a month. $28,000 the next month if you move to another facility, and on down the line. Some people have that money, we don't. So we have resorted to other ways to get by. We've done a GoFundMe for our son, which helped get us through that first month. And we thought, being naive that we were, well, we learned about this reimbursement process, but we weren't aware of the timing of that. These providers have clauses in their contracts that says, first of all, you're going to use our third-party billing agency to bill your insurance company. You have no choice. And that third party is going to take 5 to 10% of what's collected. And it can take us up to 6 months to give you back what we collect. We did not know that. We were naive. We were thinking, well, we can go skip a month, and we should have the reimbursement back to pay for that next month. It doesn't work like that, folks. You saw in that last claim of my example, which was initially filed in April, the final process claim was not till November with the insurance company. So whatever the whole $2,000 that was paid on $32,000, they can take up to 6 months, that plan provider and their third-party company, to reimburse us. And of course, we all know that the cost of care continues to increase. Our single-day billing rate was $850. The provider, as I've mentioned several times, is doubling up on that. Recommended changes to help with this whole discussion here today. Parity health and benefits coverage. It's essential. Consistent billing and reimbursement processes is, again, right now for the daily treatment or each week when he goes to his doctor, they bill $300 an hour. We're getting reimbursed 1 week, maybe $76. Next week, $24. Next week, maybe $76 again. For the exact same doctor visit, same treatment, same coding, because we're actually now with this facility submitting the reimbursement ourselves, so we're doing the entry of that. But it's paid at different rates. Ask why? Oh, I think we made a mistake there. We have to reprocess that. Okay. It's no skin off your back, but it is ours because we're counting on that reimbursement. Here's another interesting thing is treatment facilities need to educate the parents and family. We knew nothing about schizophrenia, the diagnosis. We knew nothing about the process that our son may have to go through when we went to the first facility. But that treatment facility just took him in and started collecting. They didn't care about the family and what we had to go through. There was no education involved. So it was up to us to do our research, to talk to people. Fortunately, we were connected with some people that could help us here. But a lot of families don't have that connection, the connections that we did. Very difficult. We need more public treatment facilities other than our jails and prisons, right? Because that's what it is today, folks. our jails and our prisons are our public mental health treatment facilities. We need more mental health professionals. People are leaving the industry because of how the rates are being paid. The in-network versus out-of-network. Why would I stay in-network if I can bill at an out-of-network rate and get it? People don't stay in anymore. And lastly, we need more public awareness, and that's what we're trying to do here today. So what would you do if this was your child? Please speak up. Thank you.
You really made a big difference. This is going to be a terrific tool for other families to hear your story. There's not a whole lot on record, frankly. So, blaze a trail.
Well, Julie and Victor are my heroes in so many ways, and I'd like to say, I wish I could say their case is unique. The Kennedy Forum works on a lot of different appeals, and their obviously son is very remarkable, but their story about reimbursement is not. And I think one of the challenges is when you're a consumer, it's just about getting treatment for your son. When you have a crisis like that, you go into caregiver mode. And it's overwhelming. Any of you who've gone through a similar experience knows. And I like to say that there's some objectivity behind this that you can work through, but the system really is irrational. Part of what they're dealing with is a system that was built over a quarter century ago that's not been updated. And so there's a lot of irrationality and subjectivity that goes into how coverage is determined, and just with all the different elements, and even how providers bill. So their journey's not completed, but we're blessed to have them, be able to know them and support them in our little way we can. And it's always, when you try to support someone, what turns out is you get more back. I've learned more about the appeal system working with them. So we're very grateful to how you've been able to, drive kind of our knowledge base. So thank you. You haven't seen the last of them. We're going to be working with them on many fronts to tell the story, because their son is so remarkable. And the good news is he is showing some signs of improvement. So that's a blessing. So, and I just will say one thing too. I think that everybody comes, this gets back to my earlier comment about community, everybody comes to the healthcare system with some altruistic purpose. And I, for many years, was the head of legal affairs for what's now AHIP. So I also spent some time in the industry. And I think for all of us, no matter what stakeholder perspective you represent, this is a time for us to rethink kind of what's been going on, challenge our presuppositions, and really begin a dialogue to effectuate the change that we're talking about today. So it's my pleasure next to, yeah, okay.
Is it United that was their insurance?
Yeah.
Okay. So, United Healthcare is their insurance. Let me just say it, okay? And I'd like to think of a day where we could go out to Minnesota and join arms around that insurance company with them and tell this story to the country and make those executives think, and everybody in that building think, when they walk into that company that day, what kind of insurance they're providing. I just hope that someday we could do for the mental health community what the civil rights movement did when they banded together as a community and moved, because that whole democracy initiative that Andrew Young started with Dr. King brought people together who understood the movement, and then they deployed in the places in the country where they were needed in order to advance the cause. I'm just, giving you we don't need to reinvent the wheel here. a story like that should be something they want to say quickly, let's get this thing fixed, and let's make sure it doesn't happen again. And the fact that there's no public pressure out there that can be brought to bear on an insurance company, this would never be tolerated if there were any other disease. And I'm just giving you kind of why this Parity Registry is going to be important. Because if we just get a handful of stories and we can put and document these disparities in a given location with a given insurance. And by the way, as Michael Reisman can tell you, there's no insurer out there that, well, there's probably a few that have been fortunate so far not to get dinged, but a lot of them have gotten dinged, where we can't make the case and then go right to them and say, here's the story, and have them literally fix their practices so that we don't have to have situations like this. So you know why we're here today. It's so that we don't have to face the challenges. And in the future, your story today, honest to God, there aren't too many that are out there, and because people don't feel comfortable telling them. And you've been so, courageous to come forward. Unfortunately, you shouldn't have to be courageous, but you are. And we're just so grateful for what you did today. Thank you.
All right, now it's my pleasure to introduce Amy Turner. She's had a remarkable career for over 2 decades in the Department of Labor, helping enforce the laws and regulations associated with ERISA, and is amended by the Affordable Care Act and MAPI and other legislation. So without further ado, Amy.
Well, thank you. I have to say, in my 20 years in the department, I have given a lot of presentations. I generally feel reasonably comfortable as a public speaker, and I'm very shaken right now listening to your story. It is very powerful, and I am so sorry for everything that you've been through. I will look into why you do not hear anything from the Department of Labor. I cannot comment on any investigation that may or may not be open right now by the Labor Department, but you absolutely should have received a response. So I am very shaken and very sorry, and I will personally look into it and make sure that someone calls you. I think, like Gary said, I have worked for the Department of Labor for more than 20 years, and I would say it is probably both the best and worst job anybody could have at the same time. It's the worst because it's the hardest. There are a lot of challenges, but it is the best because there are some times when we can make a difference. I have on my desk a picture of Anna Weston after meeting her mom once. I would love to put up a picture of Joey. It keeps a lot of us motivated to keep trying to make a difference. As Henry said before I came up here, there are maybe 3 phases of implementation once a law is passed, and Patrick knows much more about all the problems that go into actually passing a law, but once the law is passed, there typically is the rulemaking stage, there's the guidance stage, and then there's the enforcement stage. When we did the rules, I was part of that team. I think we fought very hard. I think Henry gave that a B, the rules themselves. I'll take that. He's a hard grader, but it's the hard graders that you always remember in life because they push you, they expect so much from you, and they push you to do more and more, and you realize that you can do more and more. So thank you for that. We did put out our rules as interim final rules. We were challenged on that in the courts, but we defended that successfully and won. We did, in those interim final rules, create the term NQTLs, non-quantitative treatment limits, which were not specifically mentioned in the statute, and I think there were some that would argue that the statute, well, some did argue, we faced that in court, Some argued that the statute only dealt with quantitative treatment limits, but the departments recognized that that was just silly, that there are so many other ways that benefits are managed and that non-quantitative treatment limits had to be part of parity. So we tackled that challenge in the interim final rules and defended it successfully when challenged in court. When we put out the final rules, we also addressed scope of services. So I think from the outset, the mindset has always been to try to provide parity. And as Patrick mentioned, I think the comparison to civil rights is a good one, not only because of its importance, but also because a lot of those laws are process laws in a way. There's no mandate that plans or employers must provide a certain number of days of inpatient mental health services per year or outpatient mental health services per year. We're trying to show that there is parity, equity, non-arbitrariness, fairness in the process. And doing that is difficult, unfortunately. So we've put out guidance. We've put out, I believe, over 10 sets of FAQs on mental health parity. We've put out a warning signs document. We've put out a self-compliance tool. We've put out fact sheets and disclosure guides to try to take this complicated concept of fairness and make it something that people can actually realize. When it comes to enforcement, the Labor Department, we're about to come out with our FY17 numbers. There are always the quality control people that are double and triple checking that everything is right before we publish numbers. I think we're very close. I'm cautiously optimistic those will be out by the end of this month. But through FY16, we had closed 330 health investigations. There were 44 violations that were cited. There are numbers on our website. They should be updated within a couple weeks with FY17 numbers. But I think maybe one of the best things to talk about here is that I think not only hearing the Hootie story, which is very important, very moving, but also talking to people, hearing about, I am aware of the Parity Track website and the new website with all the stories, the registry that's being established. I think making sure that there are good partnerships between the government, the regulated community, both employers and insurers, with the states, with consumers, is how we're going to make this happen, is by working together. I think that that's very important. The Labor Department is ramping up its investigations. We have established a national office project this year, which means it affects sort of resources behind the scenes. And we have subject matter teams that are providing support from the national office to the field offices in their investigation, zeroing in on certain major cases. So we recognize that this is important. I have spoken to Secretary Acosta about it more than once. He is very, very interested in this issue. Yesterday, I met my new boss, Preston Rutledge, who is the Assistant Secretary of EBSA. He just started yesterday. He has a lot of experience. He came from the Senate Finance Committee. He just had a few questions, and one of them was about mental health parity. I took that as an amazing sign. We had a very good first discussion about it. I think he is very engaged on the issue and will continue to support the cause, not only issuing continued guidance, but doing enforcement. There are a few challenges that the Labor Department faces that we're also talking to folks to address. One of them is resources. Just FYI, the Labor Department, my agency, does not have a health actuary. So when we talk about the complexity of some of these cases, we have one actuary in our entire agency. It's a pension actuary. We don't have a health actuary. Bringing these cases to litigation, the vast majority of the work that the Labor Department has done has been through voluntary compliance. If we have to go to litigation, if we cannot achieve voluntary compliance, it means hiring expert witnesses. We're trying to move resources in this direction, but they are tight times, as everyone knows, as we turn on CNN and wonder if the government's going to shut down on Friday. We are trying to sort of allocate things in a smart way and have had some ideas over the last couple months about how we can make sure that people are actually getting what they're entitled to. In case people don't know, we do not have direct enforcement authority against issuers. So one of the challenges that we face is, I'm not sure how you have your insurance, but if it's through your employer, to be honest, your employer may very well be on your side. I can sue your employer, but he may be advocating on your behalf. It may be the issuer. I understand it's United in this case. That is the one that's not paying the benefit. The employer may be saying, please pay. And we don't have direct enforcement authority against issuers. The states do. We work with states, but the Labor Department does not have direct enforcement authority against issuers. And we also don't have civil monetary penalty authority, which is something that the Labor Department is very interested in talking about, because if you don't have civil monetary penalty authority, what can happen, it's kind of like if there were no penalties for failing to pay your taxes correctly. You would just, a lot of people might underpay, and then if you get caught, you pay what you were supposed to pay to begin with. If there's no threat of a penalty, a lot of folks might take the risk and, well, let's see if the IRS actually catches me. So it is important to us to pursue civil monetary penalty authority to ensure that people try to do the right thing the first time, not just correct something after it's found later, after they maybe get caught. So I'm very interested in staying for the day and hearing what other folks have to say. I'm very, very happy to be there, and I look forward to continuing to work with everyone. That's it. Thanks.
I'll just say, Amy and I met with Secretary Costa, who was, as Amy said, very supportive of Congress passing a law giving him the authority to pursue civil and monetary penalties, which, is pretty extraordinary given the administration that he's part of, that they would be so proactive about seeking this type of redress. The exciting thing is that all that they would look at it from a conservative point of view is just bringing it in alignment with the civil monetary penalties already in existence for something like genetic non-discrimination, if you were to find a violation in that sense. So from their conservative background, that's all it is just aligning what is already in other codes. But from our vantage point, it would be a really big deal. And I'm very excited that, and we're working with members of the Senate and the House to put together a list of co-sponsors for that. If nothing else, I think it just continues to amplify this issue if we could get hearings, hold members accountable, and so forth. But
thank you, Amy. Appreciate it.
yeah.
Well, I want to thank Amy, as I know we all do, for her 20 years of public service. It's sometimes a thankless job, but I know she's a committed servant to help us promote mental health parity, so thank you very much. Appreciate it.